So good afternoon, and my name is Victor Peoples, and I currently serve as Director of Health and Service Initiatives for Iota Phi Theta Fraternity Incorporated. I'd like to thank you for taking the time out of your busy schedules to what we call learning just a little bit more about and understanding the trait of sickle cell disease. Tonight, I'm going to introduce to you our coordinator of the All of Us Research Program, Brother John Branch Jr.
Thank you very much, Brother Peoples, for that introduction. And ladies and gentlemen, we are honored and humbled to have you here this evening to discuss something that is in our community, something that is here, something that has affected too many of our families for far too long. We're talking about sickle cell. We're talking about understanding the trait and disease associated with this. A lot of times we use the terms interchangeably. We say, okay, I have sickle cell trait, I have sickle cell disease. What exactly does each one mean? Well, now we're actually going to discuss this more. We have a panel of experts that are going to talk about the trait and the disease and what programs that are being run through Iota Phi Theta Fraternity Incorporated in order to help address this terrible disease that has affected so many families. And at the same time, we're going to talk about the program which all this falls under, which is the All of Us Research Program. So in a couple moments, you will be seeing a public service announcement about All of Us. After that, we're going to give you links for a pre-survey. We're going to talk a little bit about All of Us, why it's important, why it matters. And then we even have testimonies from some of our brothers and from other guests on why All of Us is important, why All of Us matters, and why sickle cell matters too. So let's get that PSA going.
All across the country, people are coming together to speed up what we can learn about health. The All of Us Research Program is calling on 1 million people to join us as we try to change the future of health. For your family, for future generations, for all of us. Visit joinallofus.org and find out how you can become one in a million.
Thank you for the public service announcement. And now we're going to take a look at what the All of Us program is all about. Now, if you have your phones with you, please scan this pre-survey link, or you can click on the link that is listed for you in the chat. So this assessment is going to take a couple minutes to complete. Give you a chance to take a look at this. Everyone should have the link at this time. While you're working on this link right quick, give you guys a couple more moments to work this out. All right. We are members of the Black Letter Consortium, which consists of all the Divine Nine Black fraternities and sororities. We are all part of a program known to us as All of Us Research Program. The best way to describe this is the caption at the bottom. There's a gap in medical research that only you can fill. So what is health research? Health research is the process of finding out new things about improving people's care. Now, usually when we have this conversation, people look at it as like, okay, you have one disease, you get one way to fix it. Kind of a one-size-fits-all approach. Now, that's good for the masses, but not exactly good for us all the time. This is where the All of Us Research Program comes in. So what is the All of Us Research Program? This is a program led by the National Institute of Health, or NIH, to help researchers understand more about why people get sick or why they stay healthy. The All of Us Research Program is a historic longitudinal effort to gather data from 1 million or more people living in the United States to create a diverse health database that represents us all. And by considering individual differences in the circumstances, socioeconomics, environment, and biology, researchers may discover paths toward delivering precision medicine, which is individualized prevention treatment, and care for all of us. The most important part of this is diverse. We are all different. We are all unique. We are all special. All of us is about precision medicine, about making sure that prevention and treatment and care is for all of us. So once again, precision medicine is healthcare that is based upon each person, and it takes into account three specific factors. First one is genetics. Second one, lifestyle. Third one is environment. Now, these three sound very different, but in actuality, they are all very much interrelated within each other. And what's some examples of precision medicine? Well, for those people who have to wear prescription glasses, once again, each person's prescription is very, very different. Guess what? That's precision medicine because it's tailored to your eyesight. Blood transfusions, different types of blood you may need. Insulin pump for those who are diabetic, or hearing aids. All four of these are all tailored to the individual patient. That, ladies and gentlemen, is precision medicine. So what are some social determinants of health? There are conditions in which environments where people are born, live, work, play, worship, age, and affect a wide range of health, functioning, and quality of life outcomes at risk. Some of these you see here, some of these social determinants you see here in this chart here, we have neighborhood and built environment. We have social and community context, economic stability, education access and quality, and healthcare access and quality. Once again, all of these factors come together and affect our health in one way or another. So how do you get started with this? First thing you should do is, well, you do one of two things. One, visit joinallofus.org/together, or you could download on your phones All of Us Research app. What you should do, set up an account, complete the consent form, share your electronic health records, complete the surveys, provide samples, and you're good to go. Now, we're also part of the MSRS, which is the Minority Student Research Symposium, with All of Us research program invited underrepresented minorities to complete a research project using data from the All of Us Research Hub and present their work in a virtual poster session on Saturday, May 22nd, 2021. Greater participation of all racial and ethnic groups is needed in biomedical research. URMs represent over 30% of the US population, less than 9% of STEM PhD members, 7% of all physicians. We know that diversification of the biomedical workforce will address the critical need the US faces to reduce racial and ethnic health and healthcare disparities. And so, with a personal note, this was the virtual lounge that we were in. I will say, as someone who attended this conference, I learned an awful lot. Definitely learned from all groups involved. Just learned that healthcare disparities, healthcare issues, and healthcare research impacts all of us, not just me, but all of us as a whole. And we have to take care of each other to ensure that we're all going to be here so that this research will help us. And let's stop sharing for this here. Okay. All right. So now we're going to bring forth our first testimony. Our first testimony is from one of our brothers named Ronald Reddick, who was impacted by sickle cell, or his family was. So let's bring Mr. Reddick on here so he could share his family story about sickle cell.
Good evening, everyone. My name is Ron Reddick, and I am a member of Epsilon Omega chapter of Iota Phi Theta Fraternity Incorporated. And I just want to take a moment to talk to you all about how sickle cell has affected me and my family. So I have an older brother who actually has the sickle cell trait. And back in the early 70s, he met a young lady who his then girlfriend also had the sickle cell trait. Unbeknownst to the two of them, they had a child, and she was born with sickle cell anemia. She had a 1 in 4 chance of inheriting sickle cell, and so she did. She dealt with a lot of pain throughout the course of her life. She lived till she was about 25 years old. At that point, she had been dealing with pain to the point to where she was even on morphine. Because of the prescribed drugs that the doctor had given her, she ended up having a heart attack and she passed away And so we lost a precious member of our family through her pain and even everything that she was going through. She had a positive mindset and she was very happy with her life in spite of. Um, we also have a cousin, or I have a cousin that lives with sickle cell to this day. He is 34 years old, going in and out of the hospital quite a bit as a child, and even now as an adult, dealing with a lot of pain. And he's also had some issues, health issues, because of sickle cell, where they had to remove his spleen. He also has a port installed because all of his veins in his arms have collapsed over time from having different IVs and different things done in the hospital. So he also is a very courageous young man, very positive. He has a family, he has children, and so his life didn't stop because he had sickle cell or had to deal with these issues. It was just something that he had to deal with, and as a family, we just came together to support him as much as possible. So I would just encourage anybody that is listening tonight that if you have never got tested or screened for sickle cell, or you may want to, because if you have the trait, that's good information to know if you plan on having children, because you can pass that trait on to your child, or they can develop sickle cell as well. I'm not an expert by any means. I just simply wanted to take time to let you guys know that it's a very impactful disease to have as an individual, and the family goes through it because we can't really do anything to help. And so, love and support is about all that we can do. But I just encourage everyone to listen to the information that's being given out tonight and use it as you see fit. Thank you for giving me this opportunity to speak, and I appreciate the time. And I will be tuning in to learn as much as I can as well about sickle cell anemia. Thank you, John.
Thank you, Brother Reddick, for those words. I'm speechless at this moment in time. I will say that that's very touching. Matter of fact, you could kind of convince me to go out and get tested myself for the trait, just to ensure that my son doesn't have it in him already. So thank you for that. Before we go any further with this, I was reminded for the pre-survey, make sure that when you fill in the pre-survey, make sure you select the organization you're part of is BGLC. That is Black Greek Letter Consortium. Once again, for those of you who are filling out the pre-survey, make sure you select BGLC. All right. So we heard from a family member of sickle cell. He wants answers. We all want answers at this point in time. So now let's bring forth one of our experts that will help come up with some of these answers as to why we're affected by sickle cell. Coming forth now will be will be Dr. Jahnavi Gollamudi. She is a hematologist with the Baylor College of Medicine here in Houston, Texas. And she's going to talk to us about sickle cell disease and how it affects us.
Good evening, everybody, and thank you for the kind introduction, John. I just wanted to start off by saying I just wanted to send all of my wishes, well wishes to Ron and his family who have been going through this disease. It is truly as it's refreshing to hear a family member's perspective, because I get to see a lot in the clinic, but not hear a lot of from the family's perspective. So this is thank you for sharing that really amazing testimony, Ron. This was great. Without further ado, I just wanted to introduce myself. I'm one of the benign hematologists. My specialty is in treating sickle cell disease, and my clinic here at Baylor College of Medicine, I see a lot of patients who have sickle cell disease. So I just wanted to start off with a presentation about what sickle cell disease is, why does it affect us the way it does, and what can we do to help the disease. Disease. And I'm going to share my screen. Or let me see. Apologize for the wait. Oh, perfect. Thank you, John, for pulling up the presentation. Thank you. Okay, so next slide, John, please. So today we're just going to have two major objectives. We want to know about what sickle cell disease is and why should we know about sickle cell disease. And I think Ron already did such a good job as to why you want to know about it, but I will go in a little bit more details from the medical standpoint. Next slide, please. So before we go any further, I'm going to talk about a little bit about just a basic refresher. So our human blood contains of three major types of blood cells. And these are, next slide, please, white cells, red cells, and platelets. And each one of them has their own function, but we're going to concentrate today on the red cells, which is at the very top of the screen. Sickle cell disease generally is a disorder of red cell. More specifically, next, it is a disorder of what we call is hemoglobin. Now, hemoglobin is the oxygen-containing protein that makes your red cells basically help deliver this oxygen to the rest of your body. And sickle cell affects a part of the hemoglobin called the beta globin part. So it is in a more specifically a hemoglobinopathy is basically what I'm trying to get at. Next slide, please. Basically what causes it, next slide. It is a single genetic mutation. So we all have DNA in all our cells, in mostly our cells, and there is a sickle cell disease results from a mutation that affects a protein that makes hemoglobin. And what this results in basically is that the normal hemoglobin, as you can see at the bottom of the slide, when it's trying to deliver oxygen, is nice and far apart. And under low oxygen, a sickle hemoglobin tends to clump together. They tend to like make a long chain of hemoglobin. That results in a change in the shape of the red cell. Next point. And what that does is it changes the shape of the cell from a round shape to a more sickle shape, and hence the name of the disease, sickle cell disease. And what it does is that it causes your blood flow to not go as well or to almost stop it. And what this does is basically having like tiny little heart attacks almost everywhere in your body. And that's why people suffer from so much pain when they have this particular disease, because basically this is happening in their bones, it's happening in their spleen, it's happening in their eyes, in whatever place you can think of, it is happening. Wherever the blood flows, this can happen. So that's why it is so important to know what you have and how to manage it. And next point, please. The next one, yes. And so this is just the inset in the center is basically showing what happens when your shapes change, the red cell's shape change from a round shape to a sickle shape. And this is what results in the pain that we experience. Next slide, John. And so the question that was asked was like, so if this is such a bad disease to have, why does this mutation exist? Why have so many people have a mutation in this particular gene? And the theory is that back in the day, this particular mutation helped a lot of us from protecting us from malaria. And what it does is by changing the shape of the cell, the malaria parasite cannot get into the cell or cause as much damage. And as you can tell in this particular slide, there is an overlap of where you can see malaria is endemic, which is where it's a lot of malaria is present. And you can also see that those areas also tend to have the highest concentrations of sickle gene. So it happens mostly in Africa, in Southeast Asia, and some parts of the Mediterranean. So there are a lot of us who are affected by this, but it's it's common because of this particular trait. That's the reason why this exists. And as we commingle and create more babies, the gene gets passed on, and likely chances you meet somebody who has the mutation, you may have a baby who has the sickle cell disease. So this is how the disease gets passed on. So moving on to the next slide. And so how do we diagnose it? So basically, there are multiple different ways to diagnose it. There's a very quick way where it tells you whether you have sickle cell trait or sickle cell disease. It just tells you whether you have the sickle mutation, I apologize. And that's called the sickle cell prep. So if any one of you tonight who are listening to the program want to get tested, the solubility preparation, or the sickle prep as it's known, only tells you if you carry the sickle mutation. It doesn't tell you if you have sickle cell disease or sickle cell trait. So very important thing to keep in mind when you're looking at what test the doctor is ordering. The short way of ordering this is knowing what you have is what we call gel electrophoresis. It's a very fancy method where we look at the hemoglobins and how fast they migrate based on the electrical currents. And that is what we do. There's a picture of it in the inset, and we look at how they migrate on a gel and diagnose it. So that's one of the gold standards of diagnosing sickle cell disease. Now, the real gold standard, which is DNA sequencing. Now, here in Texas, this has been implemented since 1983. So if you're born after 1983, chances are you have already gotten screened for this through the newborn screen. If you were born before that, you may want to, and if you're interested in getting yourself tested, those are the methods available to you. Okay, so next slide. And how do we treat it? So as Ron had already mentioned, that a lot of the patients who have sickle cell disease have a lot of pain, and they often get treated with morphine, and sometimes they get blood transfusions to help with the pain itself. So we do treat the symptoms with pain relievers, and it doesn't have to be opiates. It can be a range of ibuprofen, Tylenol, as well as other non-opiate medications as well. Blood transfusions also help with treating the symptoms, and we often give it to people who come in with pain, especially if they have a really low blood count. Fluids and oxygen are the second part of the treatment as well. And we treat the disease with medications such as hydroxyurea. There are 2 other new medications, actually 3 new medications that have been approved in a very short period of time to help with sickle cell disease. And those are crizanlizumab, voxelotor, and L-glutamine. And these are available widely. And if any one of you knows anybody and they're only stuck on one medication and they can't seem to tolerate it, please let them know that there are other options available. We do sometimes treat patients also with blood transfusions if they cannot tolerate any medications. These are, I'll be honest, an extreme case of it, but most often we start off with medications itself first. Stem cell transplant is something that we reserve for people who have really bad disease, and cannot seem to get in control no matter what we try. So those are reserved for people who have stem cell transplant. And stem cell transplant is essentially curative. It removes the cells that make the sickle mutation and puts new cells in. So that's why it's almost curative. And now on the horizon, we also have gene therapy that is which is it's gone through some trials. There are dozens of people actually who have gone through stem cell therapy and are doing really well. And so it holds real promise in treating sickle cell disease. And so that is sort of all the treatment options we have available. And there are many, many more to come, because this is an exciting time to be in the research field for sickle cell disease, because there's a lot of revolution in terms of disease treatments. Next slide, please. And lastly, I wanted to relate to the audience here is that, like, even though some of the testimonies you may hear are unfortunately painful to hear, there are also a lot of people who do really well once well managed. So I just wanted to share pictures of 2 famous people, Santonio Holmes. If you click on it, and Paul Williams from the Temptations, who both had sickle cell disease. And San Antonio actually went on to become the MVP for Pittsburgh Steelers and won when they won the Super Bowl, the 43rd Super Bowl. So just want to let you know that it is possible to live long, healthy lives, even with sickle cell disease. And I would encourage you guys to work with your doctors and families, as Ron mentioned, very, very helpful as well. So with that, that's all I have for you today.
Thank you very, very much. Wow, that's a lot. Um, I'm speechless right now. And what I like to do is that usually when we have presentations, we usually take the questions immediately. But I wanted to have both of our panelists speak first before we get into the Q&A section of it. So we've heard about sickle cell disease from Dr. Gollamudi, quite eloquently, I might say, the history of it and how to live with it. But now the question becomes, what can we do about it? What programs are available to help combat this deadly disease of sickle cell? Well, one of our national partners is the American Red Cross. And we do a lot of our work via blood drives to help collect blood, to help patients. I'd like to bring forth right now, and thank you all, please hang around. We're going to bring you back in a little bit. So next up will be Dr. Yvette Miller, Executive Medical Officer with the American Red Cross. She's based out of Charlotte, North Carolina. And here she is right here. And we're now going to hear about what the American Red Cross does and can do to help combat sickle cell. And I think you're on mute. Okay.
Hi, good evening, everyone. How is everybody? So thank you so much for having me.
Okay, I want to share your presentation. I could share it on my end if you wish.
Oh, yes, please share. Thank you.
All right, give me one quick second here. Give me one quick minute. All right. I'm going to start sharing in a moment.
Great, thank you.
No problem. Okay, is it showing up or not yet?
Not yet.
All right, so sorry. Bear with me.
No problem.
All right, let's try this again. Let's try this one more time. Hopefully this works this time. Okay.
Yes.
Okay, so
Yes. Great. Thank you so much. So this slide actually is a blood drive that was hosted in Texas, and as you can see, many of those involved were African American. So what I'm going to share tonight is the role that African Americans can play in supporting the transfusion needs of patients with sickle cell disease. Next slide, please. So the important thing about sickle cell disease, and the previous presenter probably did already talk a little bit about this, but you can never hear enough about sickle cell trait. So the graphic over on the right represents parents. That's the two figures at the top of the slide are parents. They have a normal hemoglobin gene, and then they have sickle cell trait, which is represented by the blue side of the graphic of the figure. The figure on the bottom right represents an offspring that has sickle cell disease. So when you have parents that both have sickle cell trait, every time they have a child, 25% of the time, that child has the risk of having sickle cell disease. The two figures on the lower level of the slide that have that are blue and white, they have sickle cell trait. So 50% of the time, parents who have sickle cell trait, their children have the risk of having sickle cell trait. And then the figure all the way over on the left that is all clear, that child actually has completely normal hemoglobin, and that can occur 25% of the time as well. Individuals with sickle cell trait are eligible to donate blood. And we currently have a project at the American Red Cross that individuals who self-identify as African American are tested for sickle cell trait. While anyone of any ethnic group can have sickle cell trait and sickle cell disease, in this country, the great majority of people that have sickle cell disease are African American or of African descent. And so that's why at this time we're focusing testing specifically on this population. Next slide, please. So again, I included this slide because African Americans again or people of African descent have the highest percentage of newborns that have sickle cell trait, but Latinos are the second largest population, even though the percentage of Latinos babies that have sickle cell trait are sort of pale in comparison to the number of those that have sickle cell that are African American. It's still Latinos are still the second largest population of individuals that have sickle cell trait. Next slide, please. So again, the graphic of what sickle cell looks like and what the problem is. So the problem with the sickle cells is that they do not carry oxygen appropriately. So anytime our body is starved for oxygen, the primary manifestation of that, or the first thing that occurs, is pain. And that's why the pain crisis is the hallmark of sickle cell disease. And the other issue with sickle cell disease, and many of you probably remember when sickle cell disease used to be called sickle cell anemia, because we thought, the true hallmark of sickle cell disease was anemia. Well, now, we have much more knowledge about sickle cell disease, and we understand that there are a number of things that happen to the body when a person has sickle cell disease, and that anemia is only one of those things. And so now we look at sickle cell as a constellation of different symptoms, and so we call it sickle cell disease rather than sickle cell anemia, which is just one component. But anemia is a significant component of sickle cell disease. A normal red blood cell lives 120 days, and a sickle cell lives only 2 weeks. So that's why there's that constant need for blood for patients with sickle cell disease, is to combat the anemia. Next slide, please. So now we're going to start talking about the need for blood. Patients that have sickle cell disease, one of their primary treatments that they have is pain control, because again, remember, the hallmark of sickle cell disease is pain. So some of the first things that they get when they get admitted to the hospital is pain control. The second thing that they usually get is a blood transfusion, because the only way that they can get normal red blood cells to carry oxygen to the tissue is through a blood transfusion. So there's two ways that patients with sickle cell disease can receive a transfusion. First, it's called a simple transfusion, which means they only need, 1 or 2 units of blood to help resolve their symptoms of sickle cell disease. But many patients require frequent transfusions because they have a really complicated disease and they have lots of complications, and they're admitted to the hospital, weekly or monthly. So when we have patients who have significant complications, we put them on a different type of transfusion protocol called a red blood cell exchange. And this means that once a month, these patients are admitted to the hospital or to the infusion center, and we transfuse them with, and it depends on the size of the patient. A baby might need only a half a unit of blood, but as an adult, they can need 10 or more units of blood in a single transfusion episode or in a single red blood cell exchange. And so this graphic that you see is a patient that is receiving a red blood cell exchange. So that bag of blood that you see hanging at the top of the screen, that blood is from blood donors. And then those normal red blood cells are being infused into that patient. And then that little device that you see there is removing the abnormal sickle cells. And then we are infusing the normal red blood cells into that patient. And that's called a red blood cell exchange. So for any patient that is receiving a red blood cell exchange, those patients can receive, again, need 10 or more units of blood once a month. So in a given year, some patients who are on red blood cell exchange can need in excess of 120 units of blood a year to keep those complications of sickle cell disease at bay. And that's why it's so important for African Americans to donate. Next slide, please. So why do we need diversity in the blood supply? First, to meet the general transfusion needs of the population. In the United States, the most common blood type is O. African Americans and Latinos have the highest percentage of O individuals in the population. So that's why we need African Americans and Latinos to donate blood. The donor pool should reflect the recipient pool. Since most of the recipients who receive blood in this country are O blood type, donors should also have to be O blood type. So that's why we need increasing numbers of individuals to donate blood. Every 2 seconds, someone needs a unit of blood for the treatment of cancer, for surgery, for organ transplantation, for multiple trauma. When people get admitted to the hospital, in car accidents or any type of situation where there are multiple casualties, blood has to constantly be available on the shelf to meet their transfusion needs. So specifically in terms of patients with sickle cell disease, as African Americans, we have some unique attributes to our red blood cells. And so patients who have sickle cell disease, again, most of whom in this country are African American or of African descent, that blood needs to be closely matched between the donor and the recipient. And so that's why we need African Americans to donate blood to meet the transfusion needs of patients with sickle cell disease. So in general, the closest red blood cell match for a patient that needs frequent transfusions, like patients with sickle cell disease, that blood comes from someone who is of the same ethnic group or the same genetic background as that patient. Next slide, please. So these slides are really, really important and are going to make it, these next 3 slides are going to make it crystal clear why we need African Americans to donate blood. Over on the left side of the screen, you'll see the percentages of these types of antigens that are on red blood cells in African Americans. And on the right side of the screen, you'll see the percentages of these antigens on those who are of European ancestry. In this country, between 75 to 80% of those who donate blood, they are Caucasian. And so we constantly need African Americans and people from diverse communities to donate blood. So over on the left side of the screen, you'll see down, it's bullet number 4, 67%. 67% of African Americans have this red blood cell phenotype. It's called Duffy A negative, B negative. And if you look over on the corresponding side under European ancestry, basically 0% of those of European ancestry have this red blood cell phenotype. So if we're looking for units of blood for patients that have sickle cell disease, and we need for that unit of blood to be Duffy A negative, B negative, we're going to be struggling to find compatible units in that population of donors, which are primarily Caucasian. So let's look at the first two antigens. It's called C negative and E negative. These are Rh antigens. So you know our blood types are A or O or B, and then we have a positive for negative. These two antigens, C and E, are Rh antigens. African Americans have a large percentage of individuals in our population that are C antigen negative and E antigen negative. And so over on the corresponding side where you see European Americans, while there are some individuals that are of European descent that have these antigens or lack these antigens that we need for transfusion, you can still see if we're looking for units of blood that are C antigen negative, E antigen negative, and are Duffy A negative, B negative phenotype, we're going to be struggling to find compatible units in our typical Caucasian population of donors. Next slide, please. So again, this slide is really, really important. So this is actually a blood recipient that we were looking for units of blood for. So the patient's blood type was O positive, C negative, E negative, KEL, which is another red blood cell antigen, KEL negative, and JKB negative. So if we screened 250 units of blood looking for a compatible unit for this patient with that blood type, we would find a single compatible unit. Next slide, please. But if we screen 250 units of blood from African American blood donors, we would find at least 28 compatible units for this patient. So as I have already mentioned, many patients need 10 units of blood or more every time they need a red blood cell exchange. So the more African American blood donors that we have, the more African American blood that we have on our shelves, the more blood we have available to meet the transfusion needs of patients with sickle cell disease, the great majority of whom are African American. So thank you so much. Next slide, please. So in the American Red Cross, we have a project. It's called the Sickle Cell Initiative, and we started it at the end of 2019. So we had, of course, nobody could have predicted that we would have, a pandemic that would greatly have an effect on the number of people that presented for transfusion, and that would keep people from donating blood. So this project, which is now underway, our objective is by December the 31st of 2025, we will triple the number of African American blood donors in our donor base to eliminate that gap between the demand from our hospitals for this blood for transfusion for patients and providing and meeting the supply side of making sure that there is blood on the shelf to meet the patient needs for those who have sickle cell disease. So we have to triple our donor base. Our donor base is now around 3 to 4%. So you see what kind of work that we have to do with the African American community to get the number of blood donors increased to meet this critical need for blood for this patient population. Next slide, please. So I am a regular blood donor, and I've been a blood donor since I was in high school. And so I do encourage everyone this is my call to action. I donated blood for World Sickle Cell Day, which also happened to be Juneteenth. And we know how important Juneteenth for us. That's where we get together and talk about the needs of our community and how we can meet them. So I donated blood on that day to honor Juneteenth as well as World Sickle Cell Day and meeting the transfusion needs of these patients. So I am standing in the gap to help meet the transfusion needs of this population of patients. So I encourage you, my call to action is go to redcrossblood.org right now. After we finish this conversation, and make a pledge to donate blood and make that appointment and keep that appointment, because it's one thing to make an appointment but not keep it. So we have to have follow through. Make that appointment and then follow through and donate blood to meet the transfusion needs of this population of patients that need blood from African Americans. So thank you so much. I am incredibly grateful for being able to have this conversation. And, let's continue talking or answer any questions that might be in the chat. So again, thank you so much.
Thank you, Dr. Miller. Wow, another wow moment. We seem to have these. We seem to have these all over the place now. So we have a full house now in terms of the screen. Okay, we brought back Dr. Gollamudi, and also we're also bringing back here a brother Peoples, our National Director of Health and Service Initiatives. Now comes the Q&A part. This is the fun part in which we get to ask our panelists um, questions from people from the land of social media have been asking. So if someone please put the first question. Okay, the first question, and Victor, I'll let you read this one first, or you want me to do it first? Doesn't matter. I think you're on mute. I'll take care of this one. My bad. I got the first one. Okay.
No, I was going to say, I'm sorry. Before the question is asked, I would be remiss if we didn't introduce and welcome our incoming 23rd International Grand Polaris, Brother Sean Housen. He's currently on the call as well this evening.
Wonderful. Thank you. Thank you, incoming Grand Players. Hopefully you're enjoying the program so far. All righty. So our first question comes from Miss Sabrina Bro. I'm bad with pronunciations. Please don't be upset. The question is, how can we decrease or prevent the increase of addiction to pain medication in sickle cell patients when they're in severe pain and need pain medication? Who wants to take that one first? I think you're on mute.
Oh, sorry. I'll take it. Yeah, so that's a great question, Ms. Bro. And I think the first and the most important thing is that when you are in severe pain, you should get your pain treated. Now, I think what you might be getting at is how do we make sure that we are not on it long term or for chronic pain purposes. And I think there are multiple new modalities that we can use, and what we have used and every patient is, I have to be honest with you, everybody's a little bit different. We have done ketamine infusions, we have done lidocaine patches, we have done long acting like ibuprofen medications, and it all depends on what the reason for your pain is, right? So if it is because your disease is really bad, then it's also helpful to add medications or treat your disease itself at first, right? And then concentrate on cutting down on the pain medications to avoid opiate addiction, right? So there are modalities like, and these are just a couple that I am listing off, but I want you to be assured that there are ways to prevent addiction but you still need to control your pain though. So I don't want you to go ahead and say, I don't want any pain medications because I'm worried about getting addicted. You should really at first manage your pain, and then we can have other modalities to make sure that you don't get addicted to it. But that's a really good question.
Okay, Dr. Miller. Okay, do you want to speak on that one too?
Well, again, it's really important to understand what your triggers are for pain. Many people start having pain crisis, when there's a change in the weather, when it's too warm or too cold. So for me, the way that I advise patients is learn what your triggers are. And when you know what they are, then you can take the proper precautions and do those kinds of things to alleviate those situations. Stay warm, when it's cold or when it's hot, make sure that you're cool. My number one advice is stay hydrated. That can trigger pain crisis when you get dehydrated. So, know thyself. That's my first recommendation. Know thyself, know thy triggers. And as Dr. Gollamudi said, when pain medication is needed, only pain medication will do. So get pain medication when you need it, but also know with the kinds of things that trigger you and get to know how you can alleviate some of those triggers. So that's my advice. So thank you.
All right, thank you very much. We have the next question will be loaded.
So a unit of blood is about, I like to describe it, it's about 2 cans of Coke, a 12-ounce can of Coke. That's a unit of blood. 2 of those makes up a unit of blood. People can usually, understand that frame of reference. But when a person receives a unit of blood, we usually take out all of the plasma and those other components, and we give them what is called packed red blood cells, which means they're getting a little bit of plasma and mostly red blood cells. They're not getting all of the other fluid in there. And so that when we put them on the exchange transfusion, they don't get a lot of extra fluid. And so they're just getting those packed red blood cells. So thank you for that question.
So I do have a
Go ahead.
question. This is for both doctors, please. Is there a correlation with someone who has been diagnosed with anemia but not with sickle cell or having a trait? I guess the question is, can you be anemic and not have sickle cell or the trait?
Okay. Yeah. Yes, you can be anemic and not have the sickle cell trait or the sickle cell disease, and that's because a lot of things can cause low anemia. Is basically, in its simplest term, is low blood counts or low blood production, right? Or so that it could be because if you're not taking enough iron, your body doesn't have enough building blocks to build the blood, so you could be anemic for that reason. So you don't have to have the sickle cell gene to be anemic. There could be several other reasons.
Yeah, so I agree 100% with Dr. Gollamudi. Again, anemia is fairly common in this country, particularly in, I know I'm talking to the Iotas here, but you all have sisters and wives and women in your lives. Women are commonly anemic, in their young years when they're menstruating. Many women are anemic. And so, and they just feel tired. They don't really know why they feel tired. And then when they go to their doctor, and I do encourage you, to talk with your sisters and make sure that they get their annual physical, because that's usually when they find out that they're anemic, and then get put on iron supplements. So we definitely need to take care of each other, encourage women to know their iron status and take iron, because it's really, really important to not be anemic. So thank you for that question. Appreciate it.
Thank you, guys. This question is for Brother Reddick. As a family member, dealing with a member of your family with sickle cell, how difficult is it on the family? And what would you recommend for anyone that is currently dealing with a family member or themselves with sickle cell?
I guess I would recommend everybody being understanding of what they're going through, not to write it off as if they're not experiencing what they're saying they're experiencing. I'd like to go back to what one of the doctors said about knowing that the crisis is coming. Both of my niece and my nephew or cousin, I'm sorry, both knew when they were about to be in a crisis, and they would come to us and say, "Hey, I need to go to the hospital because it's getting ready to come on. It's starting to get bad." And so I would just say, just to be supportive. It does take a lot out of the individual that has sickle cell. And so you just have to be there to comfort them and just to encourage them and let them know basically that everything's going to be all right. And this is just a moment that's going to pass. And that's really all you can do as a family member. But I would tell everybody, just be encouraging and supportive.
Thank you very much, Red. That was awesome. Wow, this is great. Lovely questions so far. Lovely answers so far. So I think we have some more questions up.
I read a question in the bottom.
Yeah, it says, can you share insight on
Oh, sorry. I apologize, Jeff.
No, you're good. You're good. It says, can you share insight on how fetal hemoglobin plays a role in managing SCD and beta thal? I believe that's what that says.
Perfect. So somebody, so basically this question is going back to, I'm just going to give a little background what fetal hemoglobin is. So we all have, when we look at blood and hemoglobin per se, an adult who has no sickle mutation has two types of hemoglobin A and A2. Sickle hemoglobin comes as hemoglobin S. That's how it's just a medical nomenclature, like it's how we label the hemoglobin that has the mutation in it. So fetal hemoglobin is what babies make, and that's what the name is, like that's what the most common hemoglobin. But as we grow up, we lose that amount of fetal hemoglobin and make more adult or hemoglobin A in our blood. So this is sort of the background leading up to it. Now, fetal hemoglobin is known to be protective in sickle cell disease. In sickle cell disease, if you have a lot of fetal hemoglobin, it tends to mitigate or reduce the symptoms. And that's because fetal hemoglobin does not form those long chains of hemoglobin that we showed about in our presentation. And they're less likely, the red cells are less likely to sickle. So that's one of the reasons why a lot of the gene therapies nowadays are looking at mutations or inserting mutations that can increase this fetal hemoglobin. And that way it reduces the symptoms that you get from sickle cell disease. So that's the background on fetal hemoglobin. And yes, it's extremely important in sickle cell disease. In fact, if you have a very high fetal hemoglobin, about 20% or more, your symptoms of pain crisis or any other complications are much less than compared to somebody who has very less fetal hemoglobin. It's also another, fetal hemoglobin is also increased by getting hydria. So that's why we encourage a lot of our patients to take hydria. It reduces their symptoms by increasing this very special hemoglobin called fetal hemoglobin. I know Dr. probably Miller also has a lot more else to probably share on that too, but that's sort of the basics of it.
Yeah, thank you. Absolutely. Thank you for mentioning, because I was definitely going to mention hydroxyurea, that is really how hydroxyurea works and helps prevent the symptoms of sickle cell disease just by increasing fetal hemoglobin. Right. Thank you.
Thank you. Reddy, did you have something to add to that? Or
Well, I didn't have anything to add to what the doctors just said, but I did want to let since we have our fraternity brothers on here, and a lot of times with my cousin, as Dr. Miller said, that anywhere that blood flows, that could be affected by the sickle cell disease. And so one of the things that my cousin goes through is that he has increased blood flow to his penis. And so he could actually have an erection that lasts for an extended period of time, which that can be very painful. And I just wanted to share that with the brothers to let you guys understand how this can affect you as a man. And so I just wanted to bring that out and add a little bit more clarity to what my cousin is going through on a day-to-day basis.
Wow, thank you. Thanks,
Thank you, Ron, for bringing that up, because it's not a lot of people are afraid of bringing that up. So thank you for educating our audience regarding that, because that's a very sensitive issue. And a lot of people, I do encourage you to talk about it, because there are treatments available for that as well. So don't be ashamed of it. It's a disease. It is what it is. Right? And you need help, and we are here to help. So that's what I want to also encourage people to. Don't think this is embarrassing, and please bring it up to your doctor as well.
Yeah, this is family. It's all full disclosure. We need to talk about everything. You know how we as Black folks, there's some things that we don't want to talk about. You know what? When you have a condition like this, everything is on the table and you have to talk about it. And we do need to be sensitive to each other's needs. And, sometimes when patients need pain medication, they don't really want to ask for it because they don't want to be judged. And, people sit in judgment of them. But when you are in pain, you need that medication. So please, absolutely, we have to step up and support each other and be loving and kind and generous. Because when people in your family have sickle cell disease, the whole family has sickle cell disease. And so everybody has to step up and support those family members. And as you know, Brother Red, I'm a member of Delta Sigma Theta, so y'all my brothers. So you know, as Brother Red mentioned, you know, the whole family has to be aware of what's going on at any given time. And many families have multiple family members that have sickle cell disease. So we do have to be, it takes a village to take care of family members that have sickle cell disease. So let's just be open and kind and loving and accepting of our journey and our partnership with individuals that have sickle cell disease, and stand in the gap for them and support them.
Thank you very
So,
much. Yeah, go ahead.
how has the pandemic, how has that affected blood donations, but then also those that are living with sickle cell? As we talk about the vaccine hesitancy and stuff of that nature, are there any side effects to one living with sickle cell and with the vaccine, and or since we're in flu season, the flu shot as well?
Yeah, I mean, boy, you ask so many questions. Okay, so first with the pandemic, only about, for Red Cross, about 4% or so of our blood donor pool was African American, and this was before the pandemic. But when the pandemic hit, the number of African Americans that presented, because our community was hit really, really hard, decreased to around 1.5%, and it's still not back up to 4%. So we're still struggling to get African Americans in to donate blood to meet the transfusion needs of these patients. We absolutely understand and honor how COVID has affected the community, but remember, when blood is needed, only blood will do. So again, we take all of the proper precautions at our blood drives. We're still doing, you know, physical or social distancing, frequent, you know, use of hand sanitizer. Everyone who enters the donation site has to wear a mask. So we still have all those precautions in place. And another thing that we started with COVID that we're still doing now is every person who presents to donate blood has to have an appointment so that we can control the flow of donors through the collection site, so there's not a lot of confusion about people just sort of hanging out all over. So everyone has to have an appointment that helps control that flow. And so we really do need people, as we're starting to go back to school and start to go back to work. We absolutely do need African Americans to roll up their sleeves, make those appointments, and show up for those appointments to donate blood.
I can just add a little bit from a treatment perspective. If some of the audience has sickle cell disease, they may have noticed that maybe their doctor has switched their medications a little bit. There's a new medication on the block called voxelotor. It is supposed to naturally increase your hemoglobin levels. And so in order to preserve the blood who truly need it, like for the complications Dr. Miller had mentioned, we have switched them over to doing this new medication so that they can naturally increase their hemoglobin levels up. And so that's one of the ways we have handled the shortage of blood transfusion. And really, the ideal is to sort of go out there and donate blood.
Yeah, and I do want to add, you know, we have definitely had some reports from our hospitals that there are patients that were on exchange protocol before COVID, but we just don't have enough blood, compatible blood for them. So some of the patients actually their red blood cell exchanges had to be stopped. You know, we may find, you know, 1 or 2 compatible units for them, but we don't have, you know, the 10 or 11 units that we need for that exchange transfusion. So the number of units that we have on the shelf have been critically low. And right now, just this week, nationally, the blood supply in this country is critically low. So we went out on what are called an appeal. So we are appealing to people to please make appointments and donate blood, because the number of blood that we have on the shelves are extremely low. We'd like to keep a 5-day supply of blood on our shelves, and some of the blood types are down to 1 or 2 days supply. So if there was a disaster or there was, you know, some great need for significant numbers of units of blood, we would be struggling to meet that demand.
Thank you very much. This is great. And before we go to our next question, I just want to bring someone in right quick to give another testimony. She is the main coordinator of BGLC for all of us, and a founder woman of Zeta Phi Beta Sorority Incorporated. I will bring to the floor now Soror Jennifer Jones.
Thank you, Freda John. Oh my God, Doc, this is so amazing. This is absolutely amazing. And I want to jump on your bandwagon, Dr. Miller, and say with that call for action, now is the time. Now is the time for us to give back, lean in, help one another. This is a family. What affects one affects all. And I'm thinking my testimony is my cousin. I actually had one of my first cousins who was my favorite little cousin. She wasn't that much younger than me, but she passed away from sickle cell. Her mother had a trait. My mother and her mother are identical twins, and they both had a trait. And so Brenda, actually, her name was Brenda, she actually died at 42 of sickle cell. And I think that they diagnosed her when she probably was around 10 or so. And at that time, her expectation to live was 22. They told her she wasn't going to live past 22. And then as she grew and met that milestone and exceeded it, they told her she shouldn't have children. And she did. She had two. And I don't know if that affected her lifespan or not. But again, from 22 to I think she was 42, she lived 20 years longer than they anticipated her to live. But just watching her go through those crises and it was hard. It was hard for all of us because she has 124 first cousins, and we are very close family on my mother's side, and we all leaned in to be there for her, not really understanding the disease. And because of her diagnosis, we all went and were tested. And of my family, but my mother being an identical twin of her mother, my mother had a trait. Both of the sisters had a trait. My youngest sister has a trait, but none of us have the disease. So it's been, we need help. Like we need to do the things. Nobody's going to do this for us is what I want to say. Nobody's going to do any of this for us. And I know there's fear, there's the unknown. Like Dr. Miller was saying, there's so many things in our family health history that we don't like to share. We know Papa died of something. We don't know why, what it was, because we keep those things close to ourselves and don't share that. So we have to be able to share what's going on with our family history because it's genetic. Like we need to know that. And it's important for us and all of us in the Iotas. Thank you, brother John and brother Victor, who are part of our BGLC team that is in partnership with the All of Us research program. And it's important for us to step in. It's okay for us to raise our hand and become a part. And we need to become a part of all the things that affect our health. If we're going to help our community, particularly the Black community, to survive some of these things, then we have to step in and do that thing. We have to do it because nobody's going to do it for us. And just like Dr. Miller was saying, it needs to be Black people to give Black blood. That's what needs to happen. So we need to make that happen. So we're, I don't know, I'm going to turn it back over to John because he has a post-test, but please, people, hear this. This is information that we need. And I thank Iota Phi Theta for bringing this to the forefront because this is important information that we need to know. And I would say everybody, if you have never been tested, go and get tested. Go and get tested. It's important. It's about lives, maybe not your life, but the lives of your children, their children's children, and for generations to come. So thank you so much, brothers of Iota, for inviting me here just to share a little bit of my story about my family. But it's going to take all of us to make this thing work and get over the hump of all of this stuff. So thank you all so much.
Mm-hmm.
Thank you very much, JJ. And we'll be on a little bit tardy for our meeting at the top of the hour, so please forgive us in advance. We'll be just a little bit late, because we gotta wrap this up. So, but seriously, thank you for the kind words that you've given to us. This is amazing still. Okay, so let's bring up the next question because I'm hearing social media is blowing up with this. Next question, please. Bring it up to the screen. Can you give blood while on blood thinners?
No, you cannot give blood when you're on blood thinners because blood thinners make it easier for you to bleed. And, we use a pretty large needle when we're collecting that blood. And so it may be difficult it is difficult for people who are on blood thinners to clot and stop bleeding. So no, you cannot donate blood when you're on blood thinners.
Dr. Gollamudi, you want to speak on that topic as well?
Oh, I just wanted to clarify, like, if the audience was asking about like aspirin, because I know blood thinners is a general, it's a general term. So if you are on a blood thinner that's like Coumadin or like Xarelto or Eliquis, those I agree with Dr. Miller, and those are definitely, they're gonna make you bleed a lot. So I thought they made an exception for aspirin, Ms. Miller, Dr. Miller.
Well, so yes, you can donate blood if you take aspirin. We collect red blood cells and we collect platelets. So if you want to donate platelets, because some people do, which is a product where we just collect those platelets that help the blood clot, you cannot donate platelets if you're taking aspirin. But if you take aspirin, and yes, you can donate red blood cells. Absolutely. Again, thank you. I appreciate that.
Thank you. Thank you. And before we get to the next question, I just want to say something right quick, because I know you mentioned blood drives earlier. I think like last month I was at one of your blood drives, one of my chapters was doing here in Austin with the American Red Cross. And what you said earlier about the scheduling and the appointment stuff, like that exactly. I actually wanted to give blood when I was up there, but because I didn't make an appointment, I couldn't donate. So so that's definitely. I will say that the safeguards you have in place for blood donation is definitely effective, and it definitely is social distancing, all that stuff is something. I wish I would have taken pictures. I don't know if I would have been allowed to, but that definitely does fit that criteria.
And John, if I could just piggyback off of that right quick, and this is for both our doctors that are present. John spoke to blood drives. And so we have various chapters that are currently interested in hosting blood drives. I know we've been working with Micah with the American Red Cross as relates to blood drives. So I guess my question is, as far as us establishing or setting up blood drives in our local areas, I know Tanika is on the call right now. She's here in Columbus, Ohio, with our Red Cross agency here in Columbus. But for our other members that may be on, or members from other organizations as well, how can they host an effective blood drive?
Yeah. So the first thing, again, thank you so much for this question. So the first thing is to reach out to the local Red Cross chapter. And you can also go on redcrossblood.org and find out information about, just put in your zip code, and blood drives will come up if you want to make an appointment, but you can also find out where your local Red Cross chapter is, and then contact them, and then just start making arrangements to host a blood drive. Because we are, out on critical appeal, we are absolutely encouraging and asking people to host blood drives. And, most organizations do have a site where they can host the blood drives. We don't use those mobile units so much. We use them, but because it's really close quarters on those mobile units, we're trying not to use those as much as we were before the pandemic, because there's just not enough space for social distancing and all the things that we need to do, and all the people that have to be on that mobile unit. So we definitely are interested in people hosting blood drives. So call your local Red Cross chapter and let them know that you want to host a blood drive, and someone will reach out to you and get it scheduled. So it's so important. Thank you again for asking that question. It's just that simple. Reaching out to the Red Cross. And, there are folks, of course, that are not going to be in the Red Cross, collection area. So just reach out to whoever your blood supplier is. But the Red Cross we provide 40% of the blood supply in this country. So there are basically very few places that we cannot get to. So you can always reach out to the Red Cross first. But again, it's important to just reach out to your local blood supplier if you know the Red Cross is not in your area. So thank you again for that question.
Wonderful. This is great. Okay. Do we have any more questions to ask? Okay. Do medications from high blood pressure disqualify you from donating blood?
No, they do not. They do not disqualify you. We do have upper limits on blood pressure. So if your blood pressure is over 180 over 100, which you probably would have a headache if you had that, that will disqualify you, and it's just a 1-day deferral if your blood pressure is that high. But in general, being on blood pressure medication does not defer you from donating blood. And we encourage people to take their blood pressure medication, make sure that you are healthy and well and doing everything that you need to do to live your best life and be as healthy as you can when you come in to donate. So we really honor the space that we fill in terms of, encouraging and supporting, healthy lifestyles and helping donors be healthy as they can. And so, and most people will qualify to donate blood.
Okay, Dr. Gollamudi, sorry, I can't talk. Dr. Gollamudi, did you want to add to that, or are you good?
No, Dr. Miller is the expert here. I concur.
Thank you. Okay, let's bring up the next question then. This is good. Oh boy, here we go. Okay, we've gone. Okay, now it's time to go there. What role does systemic racism play in sickle cell disease research, funding, and/or treatment?
So we both can talk about this, but again, I'm gonna turn it over to Dr. Gollamudi. Let her talk first, but we both gonna have something to say about this. But I will turn the floor over to you.
Oh my goodness, Dr. Miller. Oh my God, that's a heavy question, and it's something cannot be ignored either. So, but right now, there is a huge initiative. So we have, like, as a hematologist, we are governed, or we have like a body that helps us out called American Society of Hematology, just like Red Cross helps with the blood transfusions. They have a big initiative to fund research in sickle cell disease. So there is a huge recognition that this disease is devastating. It has lasting effects on the patient and their families. And so there's a huge impetus nowadays to get new treatments. That's why gene therapies, like in the last 5 years, 3 drugs were approved. And before, we only used to have hydroxyurea and blood transfusions to help with this. So there is a big change, and there's a lot of change coming in terms of the funding and research per se. In my experience, in my training years, when I used to approach patients who would to participate in a trial, I've had the most amazing participation. And I think the issue is the lack of knowledge that there is a trial for them. And I think as physicians, we also need to do a better job of educating. So I think if there's a trial that you guys are interested, you should please bring it up to us, because sometimes I think, like, it's not racism per se that we don't include some people, but it just happens to be the time constraints of a clinic, of a very busy time. So there is a lot of trials going on right now, and there are lots and lots of funding and research opportunities available. And I encourage everybody and there is a big clinical trial website. It's the NCT, and I can share that link with you guys in terms of all the available trials that are ongoing in sickle cell disease right now, and any other disease per se. You could look for any other disease, but for sickle cell disease per se, for sure. But yes, there is a lot going on right now. I don't know if that answers your question, but there is a lot. This is a good time to be in doing research in sickle cell disease.
So absolutely, racism has had a part to play in the lack of equitable access to and the equitable delivery of healthcare to patients with sickle cell disease. And as the doctor already mentioned, I think 1997 was when hydroxyurea was approved by the FDA to treat patients with sickle cell disease. And then fast forward to 2017 was when the first series of newer drugs started coming on the market. So, there are there are other genetic diseases like cystic fibrosis and hemophilia that don't affect the numbers of individuals that are affected by sickle cell disease, and those two populations are primarily Caucasian. And so the National Institutes of Health and many organizations have now, had that reckoning and said that the reason why sickle cell disease has not been addressed is because it affects a primarily marginalized population. Patients who have sickle cell disease, don't really like to be called a minority, because in the next handful of years, people of color are going to be the majority in this country. There are already several states where people of color are the majority population. So that term minority is going to just sort of wear itself out over the next few years. So racism actually had a part to play. And then mistrust of the healthcare system also has a part to play. And so I have heard people say to me, why does the African-American community or communities of color currently mistrust the healthcare community? Because the healthcare community has not proved itself to be trustworthy. Because a lot of some of the things that lack of access to healthcare and delivery of appropriate healthcare still exists today. So once the healthcare community can provide that equitable access and delivery of healthcare, then yes, communities of color, may start to trust you. But until then, we're not going to trust a healthcare community. Of course, I'm a physician. I talk about this all the time, is that we know better. We have, again, those drugs. We have research protocols that we can get patients enrolled in, but there's still a lot of mistrust there. So the medical community has a lot of work to do to gain the trust and the respect of the African-American community and communities of color affected by sickle cell disease, so that we can enroll patients in these studies and get these new treatment modalities out and available.
Wow. That is a word. I feel like I'm in church right now, and I'm going to start passing the collection plate in a few moments. Oh my goodness! Wow. And I think that would be a good place to wrap it up. So we're going to wrap it up here. So I want to thank our panelists. Actually, before I thank the panelists, actually give me a chance to have your closing remarks, I want our Director of Health Initiatives, Brother Victor Peoples, to address us right quick.
Thank you, John. And I don't think you guys realized or saw how she empathized everything that she was saying. I didn't know how y'all saw when her neck was rolling. So, Pastor Dr. Yvette Miller, we appreciate how you brought the message. But no, honestly, Dr. Yvette, Dr. Jahnavi, Red, it has been a true honor and a privilege for you to take time out of your busy schedules to speak with us as an organization this evening and shed some light on this thing called sickle cell, but more importantly, how we can get involved and why we should get involved. So with that, on behalf of Iota Phi Theta Fraternity Incorporated, Community Impact Team, I thank you for your time, and we will definitely be back in touch with you again to see how we can get more involved as an organization. So I tip my hat to you both, and I appreciate your time this evening. John?
Thank you, Brother Peoples. Thank you, Victor. And before we have closing remarks by our panelists, all three of us, by Dr. Miller, Dr. Gollamudi, and also our Brother Rhett here, we're now going to announce the post survey. Please put the post survey in the chat at this moment in time. Post survey there. So, okay, once again, this is through BGLC. The link should be uploaded. And while you're working on that, let's have closing remarks. First, I want to start with usually I say ladies go first, but I want to say the best for last. So I'm going to start with Brother Reddick first, and then have the two doctors close it out. So Brother Red, floor is yours.
Yes, I just wanted to let everybody know that I appreciate being asked to give a testimony and be on the panel. I didn't even know I was going to be up on a panel with these two lovely young ladies. But I just wanted to say the passion that my sister JJ, I don't know her name, but she was very passionate about what her family was dealing with as it relates to sickle cell. And my family has that same passion. I just love what I heard tonight. I actually learned some things this evening, especially about the new drugs. I'm gonna make sure that my cousin knows about these new drugs that are out there. And I just want to say that I appreciate the time and the opportunity, and I appreciate you ladies for coming on and educating us. Thank you very much.
Thank you, Brother Red. Next up, I'm going to ask. Okay, actually, okay. Any volunteers? Which way I want to close out first? Dr. Gollamudi, you want to go first? Dr. Miller, you want to go first? Does it really matter at this point, or
Doesn't matter.
Okay, Dr. Miller, go ahead. I'll let you give closing remarks.
So thank you. So I first want to thank the organization for allowing me to be a panelist today. I really, whenever I'm on some things, I always learn something. So I really learned a lot from the testimonies. Thank you, Ron, and thank you, JJ, for giving those amazing testimonies. You rarely see that side of what a patient's family is going through. So it was a rare opportunity for me to see this. So I appreciate you, and I appreciate you sharing this with me as well. So I learned a lot. And again, thank you for the organization for letting me a part of it. Please, if there is anything or any links or opportunities that I can share with, please let me know, and I'll be happy to help. And John, if you could share my email address with the audience, or they can answer if they have any particular sickle cell related questions, I'm more than happy to answer. And with that, again, thank you and have a good night.
Okay, thank you. Okay, next up will be Dr. Miller.
Again, thank you so much. It was such an honor and an opportunity to share information and share this space with Dr. Gollamudi, and to just hear the stories from our sickle cell warriors and their families, and anything that I am now your go-to person. I know you're working with Micah, but whatever you need from Micah, he will get me involved. I am so honored to be speaking, and the call to action is please go to redcrossblood.org, make that appointment, and keep that appointment. That's my call to action, and I am just so grateful to have been with you all this evening.
Okay, thank you very much. And also, before y'all go, I'm actually going to share the emails real quick if y'all don't mind. Okay, for those of you who want to reach out to Dr. Gollamudi, you can reach her at, hold on one second here, you can reach her at JAHNAVI.Gollamudi, that's GULOAMUDI at BCM, which is Baylor College of Medicine.edu. That's for Dr. Gollamudi. And to reach out to Dr. Miller, you can reach her at Yvette, EYETTE.Miller at redcross.org.
Actually, my first name is spelled Yvette with a Y. So it's
Y. Oh, that's what I meant. Oh, I'm sorry about that. I'm sorry. I meant Y and I said E, and I don't know what's up. I mean, I don't know. I don't think I'm dyslexic, but yeah, it's one of those things. Yeah, but I'm thrilled. Thank you again. And I also want to say thank you to the All of Us team, myself, Brother Peoples, who was a co-coordinator, and also the person behind the scenes who's making all this work, Brother Gibbs Hightower IV. He's our social media lead and the one who basically makes sure all this stuff goes, make sure we didn't embarrass ourselves this evening. So, ladies and gentlemen, hope you all learned a lot tonight. Hopefully y'all got something out of this. To our guests, thank you. We are blessed and honored that you are here to spend this Thursday evening with us. And with that, ladies and gentlemen, I bid you adieu. Thank you for attending our program this evening.